Thank you. That was a great example again of, and I like the way you looked at the issues, high volume and low margin, which is what Alan and his team have specialized in trying to get access. You also spoke about the golden ticket, working with the public sector and trying to ease the way for certain neglected issues. And I heard Peter say, well, it's an unfinished story still for areas that we are championing in maternal newborn health because they may not be high volume and they may be low volume, and yet you need the catalytic mechanisms to further the access. And I heard you say, Alan, that you or the child looks at what is fundable demand and not necessarily every unmet need. How would you react to Peter's proposition that there is still an incomplete journey? And how would you react to the fact that these may be real, legitimate, unmet needs? They're not funded today, but so do we turn away from it? Or are there other mechanisms that we have to, why wouldn't you look at ways to also embrace unmet needs, which may not be of high volume?
Well, I mean, high volume can be product specific, and in some cases, even hundreds of thousands of units could be more than enough. But I think your question has to do with areas that are not receiving funding and products that are trying to enter markets that are not well established. And I think here, one has to step back and think about the public health perspective, because this is not a market in the conventional sense of consumers expressing a preference for a larger screen or a smaller screen. Much of this is driven by politics and public policy and the priorities of aid agencies. So maternal child health is very much on the forefront, but you then have to consider, is a vaccine going to be a better investment than a new test kit, a new contraceptive, a new zinc ORS formulation, or a program that could speed treatment and delivery of care at birth. So if you look at the area of public health intervention, if it is maternal child health or if it is preeclampsia, you have to look very carefully at not is this product in and of itself seem to deliver good value, but how does that value compare to other interventions that may be available across that space, or possibly even comparing that with other disease areas. So something we saw when we were active in the contraceptive space is that, as many of you would know, access to family planning generates one of the best economic return on investments for a woman and her family of anything you can do. Maybe education is in the same category. So if we can reduce the cost of an intervention for family planning, you know, we're pushing on the right buttons here, because you're going to have a dramatic follow-on effect from reduced maternal deaths during the birth experience, as well as improved health for the children. So it's difficult in some of the particular categories that Peter mentioned. The product definition and the benefit it would deliver in terms of lives saved or deaths averted per dollar invested has to be looked at very carefully to see how that compares to other choices that the donors might have.
Great point on having metrics. Peter, do you want to react and comment about the role of metrics, or what in your mind would solve this complex problem that we're all acknowledging it is?
Well, you know, what I really like about Chai's work, and it's really been fantastic, is it really takes the race to a very high level. And you heard Alan's kind of focus on donor funds like the Global Fund, et cetera. And that's really a great near-term beachhead, because it's more predictable financing. What I would say is that, and this is what we're hearing at the Global Finance Facility, is there's yet a further beachhead, which has to do with actually people in developing countries being consumers. And we just heard, for example, in this GFF meeting, that in some countries, people are, and this is well known, paying very large amounts of money for catastrophic health costs. So they have ability to pay. And the challenge, as seen by developing country public servants themselves, is actually to translate that more into an insurance scheme. The money's there. How do we channel it into a way that the costs are not catastrophic? And how do we then raise money essentially domestically through taxation systems and through those kind of voluntary public insurance systems to go even further than you could with donor money? So I think about it as a relay race, actually, the financing of this. You know, maybe the first leg of the relay race on innovation is run by foundations like Grand Challenges Canada, like Gates Foundation, like USAID. We go partway into the second leg, but there's no question that, you know, groups with much more resources can go further, like Gates Foundation. So let's say they go into the second leg. At that point, you're starting to hand off to companies. By the way, I don't really think of, I used to think of companies as a source of funds. I don't really think about them as a source of funds for innovation. I think about them as scaling platforms now. So yes, they do have a venture and a funding element associated with them, but they're really platforms for scaling. They're able to do the technical work, for example, on inhaled oxytocin or on ODON device, the regulatory work, the clinical training that's needed really, and the distribution. And then ultimately, I think the handoff is to country governments themselves. And somewhere on the sidelines, you've got people who are private investors kind of trying to get in, and they run a little bit of some of these races through great vehicles like the Global Health Investment Fund, where they've got downside risk protection, which is really the financial innovation in that fund. But they find it hard to get into the race, and that's what we need to do. We need to make it easier for high net worth individuals to actually also participate in the race. So I think about it as a finance relay race, and what I love about this conversation is you see all these people talking on the same team. They're now on the same relay team. 5 or 10 years ago, they were all arguing against each other, kind of mistrusting each other. I'm not saying that's 100% gone. But it now seems like all these parties are on the same team and running the same race. There's different legs of the race that different groups, I think, run. And the way I got into this is I think that, and Alan may want to push back, but that idea of donor funding is the third leg of the race. But again, you know, the 130-something billion of official development assistance, of which those donor funds are a part, are not, they're very significant, it's a significant amount of money, but it's not that significant compared to the 75 trillion in the world economy and the global GDP. And that's why we need the private sector. We need the domestic governments at the end of the day. At the end of the day, I don't think any innovation is going to scale without significant financial involvement of a domestic government. So I'll just end with a story. We were in Geneva at the World Health Assembly at an Every Woman, Every Child kind of brokering event, if you will. And I held up this Philips charm thing. The Philips guy was sitting over there. The health minister of Ethiopia was sitting over there. He said, oh, I'll take 16,000 of those. And then we go and we try and get WHO to help with the evidence in the rollout, because we know that it's an accurate measure of respiratory rate in pneumonia. We don't yet know whether it saves lives, and so there's ongoing evaluation needed. But to me, that is the picture of what needs to happen, kind of the participation of the innovation, a company, a country, maybe an international organization or someone else who's really dealing with the evidence in an arm's length way, and just working together on the same team. Maybe the relay race metaphor breaks down a little bit there, to actually move from idea to impact with an ultimate goal of saving and improving the lives of women and children.
Thank you, Peter. And one final, Joe, you have questions now from, I see hands up. So I just have one final question for the panel before I open it up. So one is, Peter said finance relay race, which I like that metaphor very much. So who do you work with in the same space, Glenn? Which are the other organizations? Do you consult with the CHI? Do you consult with the Gates? How do you interact with Grand Challenges? Do you all, as our organizations, are you on the same race or on the same team?
Yes.
So elaborate.
The whole community, I think, and I think I came into this late in the game in 2010 when a lot of this had already coalesced, but the entire community does feel, you know, to echo Peter's comments, like it's really rowing in the same direction. I mean, if we were looking at an opportunity in China, for example, to bring a manufacturer there as a supplier of WHO pre-qualified commodities, and CHI helped us identify the handful of companies that were A, interested in this, and B, you know, had the capabilities to do it, and then C, could deliver the volumes that would, you know, drive production costs down on a unit basis such that they could sell at very low costs in the international markets while selling at kind of medium margins domestically in China, and putting all those pieces together. So that's a specific example of working with CHI, but broadly speaking, from the procurement agencies at Global Fund and Gavi and PEPFAR and the like, to the corporate partners like BD and the big pharmas who are doing the development work, to the impact investors and the donors on the funding side who are either providing downside protection or actual capital. Linking those all together is kind of where we sit at the nexus of it, trying to put the pieces together, support things that will ultimately be purchased in volume and make a difference in people's lives, and also return profit to our investors.
Fantastic. So I see some cards up for questions. I'll start with Joe, Brenda, and then come back to you. Yeah.
Okay. Hi, Peter and others. I wanted to take this conversation in a little bit of a different direction. So this morning we heard, not against away from investment, but an investment for a different situation. This morning we heard from David Nabarro, who sort of said, one of the things that we have to think about in terms of achieving the SDGs, he used the term people, products, and process. And most of what we're talking about is product development, technology development, smoothing cost curves, et cetera, et cetera. We've been involved with a number here in New York and other places of really trying to deal with community development issues when there is not an obvious third-party funding stream. So most outside capital is happy to go into a community health center when there's Medicaid money coming in. They'll entertain, supportive housing when there's money coming in from HUD. And I want to push you a little bit to think about sort of the social intervention issue. There's one example of one that I understood failed in New York City. I don't know the details, and I think Goldman was involved in trying to reduce recidivism at Rikers Island and dealing with the cost of people being put back in jail after being released. Was the guarantee, the financial guarantee for a set of interventions that had been tested to reduce recidivism. It didn't work, is the long story short. So I'm trying to understand what are sort of the criteria for thinking about sort of social interventions, community interventions that don't involve a product or a commodity or a technology. Or is that down the road?
I don't think it is down the road, Joe. I think it's a really terrific question. It's, I referred earlier to integrated innovation, science and technology, social innovation, business innovation, but you're right, I didn't give particularly examples of social innovations, but, one story we heard here from a high public servant in Liberia is that community engagement is actually now a line item in their budget. So there's no question that these social processes are investable. I'm not sure they're, it veers a little bit more, I guess, onto the domestic government side. But on the other hand, you've got examples like the Phillips Community Life Center, which is essentially a whole process of care in Kenya, which are also investable opportunities. So I think you're right to push on social innovation. I think that the finance mix of social innovation might be different. It's certainly relevant to private investors, but I don't think that makes it any less important in terms of outcomes. David Nabarro would have talked about survive, thrive, and transform in the context of the global strategy for every woman, every child. And if you're thinking about innovations for thrive, basically protecting kids' brains in the first 1,000 days of life, a lot of those are playing with kids, stimulating kids. We know that's what's potent, and we can't let those kind of innovations and interventions fall off the map. And there is opportunity for private opportunity even there. I mean, think of a company like Mattel that might totally change their business model and use 3D printing of toys in local facilities. So I think we have to get much more creative. I think social innovation is incredibly important in reaching outcomes, very important outcomes for women and children and more generally in global health. I think the investment makeup sometimes is a little bit different, but that doesn't mean it's any less important. And at the end of the day, it may not be that different.
Well, that's a little outside my area of expertise, but just to comment, it's highly relevant, and a lot of the work that we do at CHI takes that into account. For example, in India, in looking at how you scale up zinc ORS for treatment of diarrhea at the community level, it's all about the relationships by which information and practices change. Yes, we do tend to focus early on getting the right product created at the right price, but then to see uptake across one of the states in India is very much an on-the-ground experimental process of trying to see what works there. In northern Nigeria, we're working with communities to more safely have home births, recognizing that the women are not going to go to a clinic, and therefore we have to create an environment in which the services can be provided in the village to reduce maternal deaths. So I mean, I agree with you. It's just not something that I've spent a lot of time on personally.
Glenn, a quick comment? Or? Okay, so let's go to the next question from Brenda.
Thanks, Renuka. Brenda Colatrella with Merck. So with regard to the GHIF, I thought it was worth noting that 3 pharmaceutical companies, Merck, GSK, and Pfizer, were initial investors in that fund. And I know for Merck, we viewed it as a way that we could extend our research capabilities in terms of neglected diseases through an external mechanism, and also as a way for us to be socially responsible with the potential for a small return. So we saw it as a really good mechanism for addressing social issues while at the same time trying to do it from a more business perspective. But I was curious, Glenn, if you could comment to how you make decisions, how you prioritize your investment decisions, and how do you ensure that they're aligned with the priority global health issues? I'll say, and this is not to put you on the spot or anything, but I know as an investing company, we were a little surprised by the decision to invest in a treatment for river blindness, given that there is a treatment for river blindness, a donation program for the past 30 years, and given that there's at least 4 research projects that I'm aware of, including one that Merck's involved in, to discover a macrophylaricide, which would get us to elimination even faster. So given that all of that activity was going on, I thought the decision to pursue that particular compound for river blindness was puzzling to me. But more importantly, and I guess the larger question is, how do you make those decisions? Because I don't think that's entirely clear to me, and I think it would benefit folks here to understand that.
So I'll speak broadly about how we prioritize opportunities, and I hope this becomes a bigger challenge in the future, because right now our prioritization metrics are really about finding the best overlap between high-impact opportunities, innovative technologies that can really make a difference in public health in low and middle income countries, and what's the overlap with those opportunities in opportunities that can also generate some kind of financial return. The intersection in that Venn diagram right now is sadly, quite small. We hope as global development continues and as low and middle income, residents become bigger consumers of these products, the high volume, lower margin becomes, slightly higher margin, and more products drift into that investable category. But right now it's looking at that Venn diagram and then finding the opportunities that are investable but also fit within the limited lifespan of our fund. So they have to be very late stage, and they have to have a team and a business plan ready to go today. What in politics is the oft-denigrated, shovel-ready type of concept. And sadly, right now that's not a huge universe, but we're trying to grow that universe by encouraging people to think about forcing those circles to intersect and driving more things into that piece of the Venn diagram. The river blindness treatment, and I should recognize the incredible contribution to global public health that ivermectin, the Mectizan donation program that Merck has championed for many years, has accomplished. But with that program, we thought that the opportunity behind a new compound that has a longer half-life and could be given once per year instead of twice per year was really compelling in terms of driving the eradication agenda and being able to cease treatment and mass drug administration altogether 6 to 8 years sooner than might otherwise be possible with ivermectin alone. And it wasn't us that came to that conclusion, it was really the World Health Organization, which picked up this asset after it was orphaned from a handful of mergers and strategy changes at Big Pharma. So this asset was sitting with the public health community and was essentially ready to be used in mass drug administration campaigns, but for the lack of money to bring it through a stringent regulatory authority. So when we found the mechanism to justify an investment in that, it was essentially low-hanging fruit for us in terms of that Venn diagram that I talked about at the first part of this.
So Gary, the next question. Oh, I didn't see your card up, so I don't know. But okay, Gary, and then perhaps you.
Okay, so a couple things. One is I just want to acknowledge that as far as I'm concerned, we have the leading edge thinking on this particular panel, having had working experience. Peter, and Grand Challenges Canada, who are always thinking 3 or 4 steps ahead of where things are, and it was reflected in your comments today. Alan, I have to say, and BD has neither been a donor to or a recipient of funds from the Clinton Foundation. The Clinton Foundation was so far ahead of every other organization in the early 2000s coming up with these models, practicing what we call shared value creation now in a very high impact sense before the term ever existed. And the know-how that exists in the Clinton Foundation around this is phenomenal. And then Global Health Investment Fund, really being a pioneer in impact investing and being able to do so with a return and therefore on a sustainable basis. So I want to commend everyone on this panel, Renuka, of course, but I also want to observe sitting back here how much this looks like the Wizard of Oz to me, because we have Peter there, the wizard, with the big head on the screen, and then we've got Dorothy and the Scarecrow, and we have the Tin Man, and we're only missing the Cowardly Lion, because it's all such brave people who work on these things, so there's actually no position for Cowardly Lion on this panel. And then the last thing I just want to mention, interestingly, by coincidence, Joe, I toured the units at Rikers on Friday that were piloting these advanced methods to address recidivism. If you don't believe me, here's a picture of me in the prisoner's yard, which is not a place you normally see civilians. In fact, the prisoners were yelling, "Is that the next Scared Straight group?" But in this circumstance, what's happening in those units is remarkable. I mean, we were there among very violent, incarcerated people who were not in cells, but in the room with us, speaking themselves about how much impact it's had. The issue has been when they go back into society and they face the conditions that were the same as those that drove them down that path in the first place. And many are people who have some form of treatable mental health issue that are not able to access or sustain the right treatment. They're doing incredible work. Rikers is getting a black eye these days, but my goodness, I was impressed by what I saw there.
Question.
Yeah, I'm sort of very much of a novice to this group. My career is not in the nonprofit sector, and I'm working across all industry groupings, and health is only one of them. And I'm just wondering, just listening to all of this discussion and all of these opportunities, given the fact that the digital health community is getting tens of billions of dollars of investment into all sorts of new digital health, what kind of way can this kind of group sort of merge, combine, leverage, discuss with all of these major new companies that are, very, very high risk, venture capital, hedge fund type of investment? Is there a way to sort of combine these two different things, both in the same industry, to perhaps benefit everyone here? I mean, because when I go to a meeting about digital health, the discussions are completely different than the discussions here. And I'm just wondering, how can creatively we do something to sort of combine these two different levels of thinking?
Yeah, sure. I'd love to comment on that, and I think it goes also to the questions raised by some of the other corporations about how best to implement CSR initiatives. I've spent about 7 years, the last 7 years, working with the private life sciences sector, and have observed, interestingly enough, a lot of changes, a lot of very positive changes in the attitudes in the boardroom and at the CEO level. And also that the most profitable companies in the sector are usually also the ones with the best access programs. And it has become very clear to me that the same kind of skills it takes to run a successful company are those that are needed to run a successful access program. It can't be an adjunct to the business put off in a foundation or in some separate group that doesn't have the leverage of the resources. It needs to be, oriented towards the skills, the products, the technologies of the company, and then apply some of the same analytics, business strategies, et cetera, to have a sustainable program. And what we haven't seen in the digital space, to come back to your point, is we have unbelievably wealthy companies who are frankly less attuned to than the pharmaceutical industry is to healthcare issues in the developing world. We don't think we're paying a lot of money, to Google or others, and so they maybe don't have the guilty conscience that a Pfizer or a Merck has about drug pricing. It's not a hot political issue, yet the resources are vast. And so the biggest challenge that I see in the CSR world is the difficulty in two areas. One is defining what's the right product that could really go and be successful in the developing world. What do they need, be it software information systems? We've talked about the complete absence of laboratory information systems. A simple product that's available off the shelf in the US, not available in low-income countries. And secondly, who are the partners that could really implement this? Most companies are not set up to scale their current technologies and innovations across 60 countries that are low income. They don't want to bear those costs, and quite rightly so. So how do you find a partner that can take forward the technology? So, yeah, and those are some of the issues that CHI helps with, that other groups help with, but the digital sector, the technology companies have not really done their share of what they could do. They tend to think about just the networks and the platforms and not about systems on the ground that could really help people in healthcare, so far.
Yeah. Renuka, maybe if I could just jump in.
Sure.
I think CSR is absolutely fantastic, but charity doesn't scale. And so I think completely agree with Alan that you want to see the technical expertise, the analytics, et cetera, of the companies leveraged. And even a step further, you want to see the path to profitability from those companies, and that could be a high volume, low margin path. And that's probably a point Gary made earlier related to shared value and kind of a step beyond CSR, because that's the way these things scale and will be sustainable if it actually becomes part of the core business. After all, most of the consumers in the world and most of the growth is outside of rich countries. Last year, the year before, for the first time, so-called developing countries passed 50% of global GDP. And so that's where the future consumers are. That's where the growth is for a company like PepsiCo. It's not necessarily in the United States. I wanted to make another point on Gary's Wizard of Oz thing. I think Gary is the cowardly lion. And the reason I say that is at the end of the Wizard of Oz, the cowardly lion really overcomes his cowardice and becomes the leader. And the point I'm trying to make here is that leadership and relationships really matter. And early leaders like Gary, who are working within companies at senior levels, developing business cases, often fighting against their own companies because the hurdle rates and the profitability projections might be different, but really trying to demonstrate novel business cases that serve consumers that are not the usual consumers that a company serves, and do good at the same time. It's those people that are in companies like Gary that are really going to make a significant difference. And I know that a goal of this forum is to build trust amongst the global public health leaders in the room and people in the private sector. And I just think that element of trust and social capital with leaders who are truly trying to make a difference, like Gary and others in the room, regardless of what sector they're from, and working and building trusting relationships and working in partnership, that's what's going to change the game here. So Gary, I think you're the cowardly lion because for the last 10 or 15 years, you've really been leading this in a very forward-looking way. And the flip side of that point is I think people in the room should really be oriented towards helping people like you succeed. Because if the ODON device fails for reasons of, let's say, purchasing apathy or procurement apathy or procure apathy, that is going to send a signal to other companies, and it's going to be less likely that other companies follow suit. So I really just wanted to highlight the importance of leadership, Gary, and leaders within companies who are really trying to change models from within and working in partnership with people from other sectors.
So, thank you. Any other comments or questions? Yes, we have.
Yes, thank you. David Wofford, Meridian Group International. I'm really interested in hearing more about consumers outside of the social investment field, which is really exciting. Obviously, the bottom line is getting people to go for quality health care, quality products, which then helps your investment model. We see all over the world people going to traditional healers and not pursuing as a consumer the best choice. And I was curious how you think about how you build consumer behavior to purchase healthcare products and services that are high quality, and whether that comes into your views on, it's been a lot of product focus, but how you think about the roles of business, investors, and others to change consumer behavior in countries where they show they have some funds to spend, but they're spending it in ways that don't necessarily make most sense.
Well, I think one of the areas that many people in the room probably have engaged with is the use of zinc ORS for treating diarrhea. It's an extremely simple and a very, very effective remedy, but how do you get women to adopt that repeatedly for their children? So again, one could spend hours discussing the different techniques that have been used, but that's at the forefront of activity to engage consumers in better health-seeking behavior. Contraception is another one where huge amounts of effort have been spent, continue to be spent on educating women to have the choices available, both in the private sector and public health clinics for family planning. So it is something that is, I think, at the forefront of our minds. A particular example that I had experience with on a pharmaceutical is giving infants AIDS drugs. Alcohol-based syrups or pills that you can't swallow, don't work. So what we needed to do based on consumer input was, that they would not use the medicines, the mothers wouldn't give them to their children, was design a product that would dissolve in milk or water that was properly flavored, but would still have the necessary drugs in it at the right doses. So I don't want to give the impression, in fact, I'd like to give the opposite impression, that it starts with trying to understand what will really sell, if you will. What is the actual product specification that works with the consumer and from a public health point of view?
So I'd like to just wrap up the session with a few closing comments here. Incredible panelists, really. We heard themes of push versus pull, engagement of domestic government, the importance of having a dual market or a return on investment and economic justification, especially when you're looking at a lifeline and say you want to accomplish these programs, but working at the same time in collaboration with other players in the field. Really the unique perspective of CHAI to say how do you drive access by engaging locally and globally wherever necessary and with donors and governments. To look at fundable demand and not to forget that there are multiple health priorities, so picking the ones that you can address well first. These are all incredible lessons, and this forum is looking at developing an accountability framework that will enable people to readily look at models, readily look at how do you make public-private partnerships more successful and scalable. So I'm sure we'll tap on your expertise going forward, but I personally have the pleasure and privilege of working with each one of these players, with Alan pretty much on a daily basis now as we're trying to solve some very complex problems in both family planning and HIV space, with Glenn Rockman on bringing forth some groundbreaking technologies, as with Peter in looking at how do you establish this pull mechanisms for devices that are, and devices or diagnostics that are in the pipeline, which we know will have an impact. So it's just been a pure pleasure. I really request you, ladies and gentlemen, to please join me in thanking our panelists for this wonderful session.
Thanks very much. Bye-bye.
Thank you. And I think as we move on to our next session, I'd like to introduce, I'd like to invite Bruce. Okay, let's take a 5 minutes break as we regroup and get ready for our next session. Thank you.